Professor Meier, you started the Rush Mother's Milk Club, and which year was that?
I started the Rush Mother's Milk Club in 1996.
At that time, only 17% of mothers were actually pumping their milk or breastfeeding.
17% of the mothers at the time I arrived were in any phase of actually providing milk for their babies. So that involved mothers that were just delivered all the way through to mothers that were going home. So total. But an average of about 5% of the mothers that actually began providing milk were still continuing with those efforts at the time the babies were discharged.
And now you say that 98% of the mothers are providing their own milk to their babies. Do they also continue after discharge?
Yes, well, our initiation data for our 5-year NIH-funded project is where we collected the 98%. We've always known it's somewhere around 95 to 100%, and we don't see any differences based on race or geography or ethnicity or income, because our message is so strong about your milk is so important. But of those 98% of the mothers, about 50% of the mothers initially had planned they were going to feed formula. So we have changed their decision to provide milk. And some of those mothers say, well, I only want to provide milk while my baby's in the hospital. Other mothers will say, well, I'll try it for a month. So we are very focused on helping the mothers establish the breastfeeding goal, which is what I referred to based out of our research, and helping them achieve that goal. So we benchmark many things other than just who goes home still getting milk, because that's not the goal of some of the mothers.
It's fascinating that you just said 50% of the mothers intended to feed formula at first. And because you also said in your presentation that you have mothers coming from other hospitals, and when you begin to share with them the scientific facts about the value of their milk and how important it is, they get very angry that at the previous hospital they were just told, it's your choice, which I think most people think is what mothers want to hear. It's their choice and they don't want any pressure. So why do you think that you're so successful at keeping away from that kind of polemic discussion that people are having a lot, and getting people to listen really to the science?
So I think this goes back so far with where we began with our program in 1996. Because when I arrived in that program and was given the job of Director of Lactation Services, there was no previous person. So I was creating a program from the beginning. So I began with really focusing on why we wanted to do this, which was really completely evidence-based. Quite frankly, I never mentioned the WHO code. I didn't mention anybody's recommendation. It was just based, these are what the studies show. So that little by little, the neonatologists were the people that began to say to the mothers when they would consult with them antepartum, they would say to them, if your baby's born at 26 weeks, your baby will likely need a respirator. Your baby will need blood transfusions. And what I need from you is I need your milk to help reduce the chances your baby will get a complication. So that began with the physicians. And then it was followed up by the breastfeeding peer counselors that really worked with the physicians. The physicians gave the message about why it was important. The peer counselors came in with, this is how I did it. I changed the decision too. This is how I made it work. This is how I had to work with my family so they would understand it. That, in the combination with those milk club meetings where the mothers could all be together and discuss those strategies, were very, very powerful ways of changing that decision. But that was when I had a PhD student, because we try to integrate the PhD students into the research the team is doing, so they learn to do research the right way. So this was Dr. Miracle, who is her name now, Dr. Donna Miracle. This was her dissertation topic, was using a multi-methods approach to understanding what influenced the mother's initial decision and what influenced the changing of the decision. So it was in that study that the mothers commented that they hadn't been told in other hospitals, and they were the mothers that were angry. So this is, if you read, and that was, what, 12, 13 years ago. The literature now is really pretty solved with that in terms of what does the evidence show, and it shows mothers want that information. It does not make them feel guilty. But I think there's a little upward comfort curve with care providers initially, because you do feel, I didn't, but I know I've mentored and walked many of them through how to do this. And once they see that it doesn't intimidate the parents one-on-one, then they become very able to help other people and to continue with it. So it was creating an evidence culture in the whole intensive care unit.
So that's interesting, because I wonder if it's possible to do this also with the parents of term babies, to help to educate them in a non-threatening way.
All the mothers will talk about the fact they know breastfeeding is best, but they don't think their milk is best for their baby, or there isn't that much difference between formula milk. Breast milk is better, but formula is not that much different. And I think, again, if those mothers had strategies from somebody about how to get through that first 14 days, because that 14-day period isn't just premature babies. If you look worldwide, that's the period we see early unplanned weaning, because that's when the common problems, that's engorgement, sore nipples, your baby needs to feed so frequently, you think there's not enough milk. So that first 14 days is the real difficult time for everyone. And I think if mothers had a supportive peer counselor instead of perhaps their own mother who's saying, I told you it wouldn't work, you just need to give the baby formula, that we would probably at least begin to replicate that with term babies.
The breasts everywhere. I think that was so funny. Yes, the neonatologist came in and said, I don't want to say anything against breastfeeding, but there are breasts everywhere. And how typical is that actually still, because you travel around the world and you're trying to help other people to implement similar programs?
So the breast everywhere comment just takes me back to the whole idea that I've said for so many years, privacy is overrated. People will use the infrastructure as an excuse for why they can't do X, Y, and Z. We can't do skin-to-skin care because we're too crowded. We can't do breastfeeding because we don't have privacy. We never had any of that. But what you create as a practitioner with enthusiasm is where there are babies, there should be breasts. And it doesn't mean that you need to sit with your breast exposed, but that you can have your baby in skin-to-skin care, or you can be breastfeeding your baby, and it's nothing that you need to feel uncomfortable with in a newborn intensive care. You don't need a private room. And I used to leverage the benefit of that in many ways by having the mothers that became very good at it help the other mothers. So you've got a mother sitting here and a mother sitting here, and this mother is in deep grief because her baby's 24 weeks. She doesn't know if the baby's going to live. This mother's baby's 2 weeks later. I say, oh, come over here and watch. 2 weeks from now, we'll be doing this with your baby. And that was the beauty of using a big open bay unit. You can do that now, but it takes more planning and it's more difficult. But that's the beauty of a big open bay unit, where the women, or the families basically in general, could see that this was just normal. It was the way that nursery was.